Good morning. Welcome to In the Trenches with DAC. Today's topic is plasma cell dyscrasias. This was requested that I speak. This topic, my house staff and students requested I speak on, and I'm going to try and do this off the top of my head without preparation. So, with plasma cell dyscrasias, obviously these are abnormalities of the plasma cells, and the big one is multiple myeloma. And we'll focus our time on that. Okay, now the other things I want you to be aware of, something called MUGUS, monoclonal gammopathy of unknown significance, amyloidosis L, Poem syndrome, and scleromyxedema. So these are the other plasma cell dyscrasias, also light chain deposition disease. So let's talk about multiple myeloma. This is the second most common hematologic malignancy. The most common hematologic malignancy is non-Hodgkin's lymphoma. Multiple myeloma is number 2. Okay, so when do you suspect myeloma? Okay, this is an abnormality of protein, but who are you going to expect on? So with multiple myeloma, you're going to make the diagnosis. There are really 3 components. There are protein studies, bone imaging, and bone marrow. So the protein studies, they have an abnormal gamma globulin. Okay, you get a serum protein electrophoresis, you're going to see elevated gamma globulin. Okay, but you're going to see a spike. It's not going to be polyclonal, it's going to be monoclonal, so you're going to see a spike. Now, the higher the gamma globulin, the more concern it is. But to have myeloma, you need a gamma globulin at least greater than 1.5. Okay, but that's number 1. Now, if that's elevated, then you're going to do a serum immune electrophoresis, and you're going to get quantitative immunoglobulins, IgG, IgA, IgM. Okay, a couple pearls. Myeloma is usually IgG or IgA. You can see IgM myeloma, but IgM myeloma is very rare, and usually with an M spike, IgM, it's Waldenstrom's macroglobulinemia, which is really a lymphoproliferative disorder. It's more like small cell well-differentiated lymphocytic or small cell non-cleaved lymphocytic lymphoma. There are IgD and IgE myelomas, not common, usually IgG and IgA. Okay, so you're going to get quantitative immunoglobulins. Now, one of the bugaboos here is, say you have an IgG myeloma, that'll be elevated. That will be elevated, and the other ones will be suppressed. So if your IgG is elevated and your IgA and IgM are suppressed, it's more of a suspicion of myeloma. Okay, however, a certain subset of myelomas do not produce heavy chains, okay, and they're not going to produce gamma globulins. They're just going to be light chain only. And really the best test to get serologically for myeloma are serum-free light chains, okay, and you get a kappa lambda ratio, and you know, if it's over a certain level, that makes you really suspect multiple myeloma. So those are protein studies. Now, we're going to move back. Monoclonal gammopathy is monoclonal gammopathy of unknown significance. Somehow the patient has an M spike. It's usually not that high. These people, they have about a 1% per year chance of converting to multiple myeloma. Okay, and risk factors include elevated serum light chains, more of an IgG, and a higher than baseline M spike level. Those are really the risk factors. Then there's something called indolent myeloma, which is myeloma without organ involvement. So you have multiple myeloma, you have this indolent myeloma, where you have the abnormal protein studies, but you don't have something called CRAB, C-R-A-B. Okay, so C is calcium, R is renal involvement, A is anemia, and B is bone involvement. That's CRAB. So that's the key for symptomatic multiple myeloma. So to diagnose myeloma, you have the protein studies, you have CRAB, and the next thing, they often do a bone marrow, okay, and you're going to see greater than 10% plasma cells in the bone marrow, and they're usually immature, they're usually plasmablasts. As far as bone studies, you're going to, once you have myeloma, you're going to have to stage it. And most of the lesions with myeloma are not osteoblastic, and a bone scan's just going to light up osteoblasts. So a bone scan's not helpful. You have to do a total bone survey, and you have these mothball-like lesions, and you have to look. They're lytic lesions. They're not blastic. There's a subset of myeloma called osteosclerotic myeloma, which could cause which could cause abnormal bone scans, and they do have blastic lesions, but you usually don't see that. So that's how you diagnose it. Then you need to stage it. And there are a couple different staging systems, and without going through the details, one I think is called Dury-Salmon, and the other is the International Working Formulation. Dury-Salmon looked at 5 things: hemoglobin, calcium, IgG level, IgA level, and then urine proteins. And you could stage it. I'm not going to write these things on here, but these are things they look at. The newer staging International Working Formulation looks at 2 things: the serum beta-2 microglobulin and the serum albumin. Okay, so if you have myeloma, you have to categorize whether it's IgG or IgA, or maybe one of the other less common immunoglobulins, or non-secretory myeloma, and then you need to evaluate the stage of the disease. Anemia is usually due to bone marrow invasion. Hypercalcemia, and it's one of the malignancies that could do that. They used to call the mechanism something called osteoclastic activating factor. That term is not really popular now, but you have increased resorption of bone, and that's something you can see. You also have renal involvement, usually not glomerular. Okay, it involves cast nephropathy. Okay, it's a tubular interstitial disease. When you dip the urine, okay, the urine dipstick just shows albumin. Okay, so the urine dipstick could be negative for protein. They have more globulin, and classically, the way we used to diagnose this, we'd send it for an SSA protein. Now, hypercalcemia could contribute to renal insufficiency, and sometimes myeloma subset could be associated with amyloidosis L, or something called light chain deposition disease, which can involve the glomerulus. But it's usually a cast nephropathy involving the renal interstitial, and then bone involvement is common. That's kind of how you diagnose multiple myeloma. And myeloma is a disease that's treatable. And back in the day, when I was a resident in the early mid-'80s, we treated it with prednisone and an oral alkylating agent, and these people would live 3 to 5 years. You know, now they use biologic agents, okay? So they usually use lenalidomide or thalidomide, these biologic agents, and there are other agents that are also involved. And then often a bone marrow, a stem cell transplant is done also. And that's not curative, but it could add like 3-4 years to the patient's life. When people are on some of these biologic agents, plus steroid like dexamethasone, that's a thrombogenic combination. And some of the hematologic guidelines involve putting these people in VTE prophylaxis. The other thing you have to realize about multiple myeloma, okay, that it's an abnormality in B cell and humoral immunity, because beta cells produce plasma cells, which produce antibodies, and you're not producing antibodies. You need to make sure these people have pneumococcal vaccine. You need to make sure that they're vaccinated. And if there's bone involvement, often bisphosphonates are also used, like Zometa, to prevent bone fractures. Now, this is a condition that's not going to be managed by an internist. It's going to be managed by a hematologist. It's going to be managed by a hematologist oncologist. This is the primary plasma cell dyscrasia. You know, the indolent myeloma, you know, the myeloma where you don't have crab, often these people are followed, and a certain percentage each year will develop myeloma and then will be treated. And Muggis in itself, you know, you just have to watch them. But it's been reported associated with peripheral neuropathies. It's been associated with the membranoproliferative glomerulonephritis. There are other things you could see with Muggis. Amyloid L, I don't want to get into because that's a whole different disease. These people have nephrotic syndrome, cardiac involvement, and a subset of patients with multiple myeloma could develop amyloid L. And if you have somebody with multiple myeloma who has nephrotic syndrome or nephrotic range proteinuria, you have to think of amyloid L and do the appropriate biopsying and staining for that. Couple other things, Poem syndrome, you know, that's an interesting condition. You may or may not see it in your career. Plasma cell dyscrasia, organomegaly, more in the spleen, endocrinopathy, more hypogonadism or hypothyroid, an M spike, and skin changes. This is peripheral neuropathy. This is the M spike. This is considered in these plasma cell dyscrasias a very interesting disease. It involves cytokines, and it's often treated with Avastin. Scleromyxedema is a skin condition where you have edema and you diagnose that by biopsy, and it actually falls in the category of these plasma cell dyscrasias. And you know, that's basically it. This is an approach. So let me just summarize this. This is a common malignancy. Okay, somebody who has anemia or renal insufficiency or hypercalcemia or bone pain, and you don't know the etiology, you have to think of this. You have to do the appropriate diagnostic tests, the protein studies, bone marrow, and possibly bone imaging. And I'm going to stop right now. This is DAC in the trenches.